All right, we're going to go ahead and get this next session started. I'd like to introduce Dr. Michael Belfort. He's going to talk for a little bit. He's our OB-GYN-in-Chief, and this session, as you can see on the background, is not about the technology. So without further ado, Dr. Michael Belfort.
Good afternoon, everybody. Do I have to hold the microphone up?
Yes.
Okay. It's my great pleasure to be here this afternoon and to welcome everybody to the pavilion, to an awesome facility. How many people here do not work here? Aren't you guys impressed? Don't you wish you did? So this is a almost $600 million facility that is dedicated. I think, do they know all of this stuff? Have you told them all this stuff already? You haven't bragged about it? Okay, and I'll brag a little bit. Almost $600 million, 1.2 million square feet facility dedicated to women's and newborns and their care and some ancillary services. And we'll talk a little bit about some of the innovative and I think differentiated programs that are housed under this roof. The concept of the Pavilion for Women is clear. It's comprehensive health care for women. It is obstetrics and gynecology and neonatology and fetal intervention, which is a reasonably new concept where we're doing fetal surgery on in utero fetuses for congenital anomalies. And the story that I'll tell you this afternoon is about one baby that has benefited from that. So it's a little bit about the technology, because without the technology we wouldn't be able to do a lot of what we do. But it's really about you. It's really about the people and the programs. And despite this wonderful building, without the people and the programs, that's what it is. It's a wonderful building. And without the technology, or with the technology, it's still a wonderful building. It has to have the people and that desire to make the difference that we see in people at Texas Children's every day. So, fetal surgery. What is fetal surgery? Fetal surgery or fetal intervention is designed to do a number of things. One, it can be life-saving in utero, but two, it can also improve the chances of the baby after birth. So some of these children that we work with and operate on could be born and be alive at birth, but without the fetal intervention, their long-term outcome may be worse, or they may have a higher risk of dying. There are some interventions that people have heard about, maybe the laser. People have heard about using laser to separate the placentas of so-called monochorionic diamniotic twins, twin transfusion syndrome. And that is a process where we will put a small fetoscope into the uterus, identify on the surface of the placenta abnormal connections between the two cords of the babies, and we will laser those connections closed. And that is life-saving. If you do nothing in a twin transfusion case, there's a 90% chance of losing both babies. With the therapy, the chances of taking home one baby are about 80 to 90%, and the chances of taking home two babies is around 60 to 70%. So a dramatic reversal in the outcome. So that is certainly one intervention that is this always happens. It's probably my wife. No, it's not. It's our fellow. He's probably trying to find. Tell him where to go. He's trying to find this place. So The next intervention I want to tell you a little bit about is a program that really we're, I think, the only place actively offering this procedure in the United States, and that is called intratracheal balloon placement. It's endotracheal occlusion, and it's done for a congenital condition called congenital diaphragmatic hernia, where the baby... I hope I'm not talking down to people. Is everybody medical here, or is this the reasonable... Okay, so am I talking at the right level here? Yeah. Okay. This is a condition where the baby's diaphragm, the muscle that separates the abdomen and the chest, is deficient. There's a hole in it. And what happens there is that the lungs, the liver and abdominal contents can get into the chest. And the result of that is that they prevent the lungs from growing. So the baby does fine while it's in utero because it doesn't need lungs. It's got a placenta. And then it's born and it has no lungs, lung hypoplasia. And a lot of these babies die very, very rapidly. Well, the procedure that we do is done usually at around 25 to 26 weeks. We put a fetoscope into the uterus. We then put it into the baby's mouth, down into the windpipe, and deliver a small balloon, a detachable balloon in the windpipe, and we blow that up. And that blocks off the windpipe. The lungs are continually making fluid. When you block off the egress of fluid from the lungs, what happens is the lungs slowly expand and increase in size, and then there's a part that we don't understand. Why that helps, we're not sure. It's not because it pushes everything out of the chest. We think it's because the stretching of the lungs actually stimulates growth. And so that what we do know is that you take a condition that has around an 85% mortality and you turn it internationally on published data to around 50% mortality. Now, I will tell you that we've done, in our new program, we've done 8 cases. 7 of those babies are delivered and 7 of them have survived, which is, touch wood, we're hoping to continue with this. That's remarkable survival. They're still sick kids. They still need the surgery to repair the diaphragm, but you're taking a condition that is almost lethal and turning it into something that is definitely survivable. And some of the first kids we did are starting to walk now, and they're delightful little children, and they're normal, and it's an amazing thing. And so my final story today is about a lethal condition, and this is a condition called hypoplastic left ventricle with intact interatrial septum. Okay, it's a lot. What it is maldevelopment, usually of the aortic valve, which is the outflow of the left ventricle. So what happens in a baby that has an intact, well, let's say in a normal fetus, which has that normal hole in its heart, okay, between the 2 atria. Remember, babies have this little hole in the heart. It's called the foramen ovale. When you don't have a left ventricle that's pumping properly, and you don't have a way for the blood to exit out of the heart through the aorta, when the ventricle pumps, it'll pump the blood back, but it's still got somewhere to go. It'll go through that hole in the heart into the right side of the heart and then find its way back out through the aorta, through the ductus. Okay? We don't have to get too technical. But when you have no way out of the heart through the aortic valve, because it's atretic or narrowed, and that little foramen ovale is blocked off and has no hole, you can see what happens. Blood comes into the heart and just stops. It doesn't go anywhere. And the result of that is that baby at birth dies within minutes, because the blood that goes to the heart to get oxygen comes back to the left side of the heart and stops. So we have a technique at Texas Children's Hospital that was actually developed in Boston at Boston Children's. We learned from them of placing a needle into the beating heart of the baby, then putting a wire through that needle and across the septum, and then running a coronary artery stent that's usually used in old guys who have heart disease. Okay, we've used that because it's all that's available. We're trying to get the money. Anybody out here has got a lot of money and wants to donate it, come see me. We're trying to develop new devices and new techniques for doing things in fetuses, designed for fetuses, not designed for old guys with ischemic heart disease. Anyway, that's the best we could find, and we used this coronary artery stent. So we ran it down the needle, along the wire, into the fetus's beating heart, under ultrasound. This is all being guided inside the mother's uterus, and then expanded the stent with a balloon, and it pops the stent open, and it makes this hole between the two sides of the heart so that at birth that baby doesn't die within minutes. The baby still needs a Norwood procedure, still needs a lot of surgery, but it turns what is an absolute emergency at birth, where you're trying to do this procedure after birth when the baby is already deteriorating in front of you. And quite frankly, most of the time those babies die while they're still trying to get access. It turns that into a situation where the baby comes out and cries and looks and acts normal. So, baby Grace. Let's talk for a few minutes. I know I've probably gone over my time already. I'll just be a few minutes and I'll tell you about baby Grace. So she came to us at around 22 weeks. And she had this condition. And we spoke to her parents. And at that point she didn't have any name. She was just a little baby girl with a bad heart condition. And we offered her this procedure, and the parents accepted the procedure, and we went to the operating room and we did the procedure. And what happened then is the remarkable part of the story, because when we blew up the stent, this baby's heart basically stopped. Something happened. It may have been too close to the AV node, the SA node, who knows where this thing was. But within minutes, the baby's heart slowed down and essentially stopped. Up until now, that's the end. That is the end. But that day, something very remarkable and strange happened in that operating room. We were not going to let this child die. And so we did everything that we could think of. We punctured this child's heart, I think 11 times with drugs. We were giving direct intracardiac epinephrine, everything that we could think of, but the heart was just sitting there in what we call PEA, pulseless electrical activity. There was no pumping of blood, and essentially this baby was dying or dead, close to just with a little fluttering heart. And then where it came from, who knows, but the idea came along that what would we do with an adult? Well, we'd try cardiopulmonary resuscitation. Well, how can you do that on a fetus? How can you do that on a 22-week fetus? Well, we had the ultrasound. We were able to see the heart. We could see that it wasn't doing anything, but if we pushed on the ultrasound, we could actually see that force being transmitted. So we pushed a little bit harder and harder until we could actually see the baby's heart start to get compressed with the ultrasound probe. And then it became very apparent that we could do, and I believe it's the first time that it's ever been done, intrauterine cardiopulmonary resuscitation on this fetus. And we have video of this, and I should have probably brought it because it's remarkable. You can see this baby's heart being compressed, almost completely. And within a few minutes, the heart started to pump, initially very slowly, and then it came back to almost a normal rhythm. and baby Grace was alive. Problem was, the stent had been dislodged. When you start pushing on somebody's heart to this extent, the stent was dislodged, but there was still enough of a hole where the stent had been to keep this little girl alive for about another 8 weeks. So at 30 weeks, we were all very disappointed to see that her heart started to dilate. She started to get massive pleural effusions, and we were back where we started. What hadn't happened was that in those 8 weeks between the initial procedure and when she got really, really sick again, we did not see any damage to her brain. And this cardiac compression, I think, went on for about 20 minutes. And there's no question this baby was incredibly acidotic, but it was successful and she didn't have any obvious brain damage. So now we're back where we started. Well, not where we started. We're back with a traumatized family, a baby that's had a long cardiac arrest but still now has a devastating cardiac condition. So we did the only thing that we could do, which is go back to the family and say, we've got to do this again. And of course they accepted it again, and we went back, and thankfully baby was a lot bigger. The stent went in beautifully, the stent functioned beautifully, and baby Grace grew until around 34 weeks when she just stopped growing. And so we did an elective cesarean section, and she came out at 2,100 grams. And she cried, and she was just looking perfect. Next problem is the Norwood procedure, which is the life-saving ongoing cardiac surgical procedure, really has about a 50% mortality when the baby's less than 2,500 grams. But she needed it. So here's another huge hurdle. So she got a first stage Norwood procedure, and they did a Sano shunt, which is essentially a shunt from the right ventricle, the only ventricle really, to the new aorta, and it didn't work. So the first few days there she was with a little chest open, and she had to have another cardiac surgery, this time for a Blalock-Taussig shunt, and that worked. And I'm happy to tell you today she's lying in our CV ICU. She's eating, she's awake, her color's good, she's had her first stage Norwood, and in about 2 to 3 months she should get her Glenn and then hopefully her Fontaine. And one day I'm waiting for her to come and talk to me, and that'll be for me an amazing day. So that is the story. The part that I want to highlight is that this took a team of people. There must have been 30 or 40 people in that room, and there must have been even more people who touched this mother, father, and baby's life, and probably hundreds more now since she's had 2 cardiac surgeries. And the kudos for this need to go out to our nurses, to our technicians, to all the people in the background who never get any of the praise. You know, it's always the doctors. It's always the focus on the doctor. But without the nurses and all of those people who make this hospital function every day, and yes, the technology that is available to us, none of this would be possible. So from the physicians, I would like to say thank you to our wonderful Texas Children's team. All the nurses and the operating room staff and the technicians and the lab people and everybody that I haven't mentioned because I can't think quick enough. Thank you. And thanks to you for being here today.